Hi, my name is Louise La Plante, and I am a behavior support consultant and a licensed independent social worker who works with people on the developmental disability waiver program in New Mexico. This video is about psychotropic med use and monitoring for adults with intellectual disabilities. This is not a standalone video. It should go along with a training by a trainer. But if you want to watch it, you will gain some information about psychotropic meds. If you'd like to request handouts to go along with this training or to schedule the complete training, go ahead and comment in the comments section. Here's the agenda up on the screen that we will be talking about today. If you want more information on this, any of these topics, you probably want to consult with a professional. Psychiatrist is probably going to be the best source of information, and there's some ideas to get you started in the reference area of your handout. So we will talk about what are psychotropic meds and why it's so important to monitor them, especially for people with intellectual disabilities. We talk about the team responsibilities, prescriber responsibilities, a lot of cautions, because psychotropic meds are pretty serious medications with a lot of side effects, and sometimes they're overprescribed. We're going to do a quick review of some of the medications that we're actually talking about and how to talk to prescribers and some of the more serious side effects that are pretty common with some of these meds. If you're watching this, you should have watched a NAMI YouTube that your trainer will show you. You can see the link on the screen if you're watching this without a trainer. So what are psychotropic meds? Psychotropic meds are designed and intended to treat and manage or control symptoms of psychiatric disturbances or illnesses of the mind. And that's an old description, but it still is true today. There's really only 6 reasons to use psychotropic meds, although sometimes we will see other uses for them. But we should be using them, prescribers, doctors. I'm not a doctor and I don't pretend to be one. I don't play one on TV, and I'm not any kind of prescriber. So this is really for those of us who are non-prescribers. But we still should be aware of the reasons for them, and that's to treat a clearly diagnosed primary psychiatric illness. Sometimes they're used to treat medical conditions. Very occasionally used for extreme behaviors which interfere with important aspects of a person's life. This is a slippery slope one because we don't want to be using them for challenging behaviors if we can address the behavior in a more humane and less intrusive way. Number 4, for empirical reasons to address severe dysfunction that has been resistant to other intervention. Number 5, to treat medication withdrawal or discontinuation symptoms. And number 6, for sedation during a medical procedure. A really good source that I think anyone that's working with people who are prescribed these meds is No Easy Answers. A link to an online copy of that publication is included in your handout, and it's also on the screen here. So why is it so important to monitor psychotropic meds? Just in general, why is it important? And these are potent medications with serious long-term side effects. These medications should be carefully monitored for anyone who takes them. And especially people with intellectual disabilities who might have limited communication skills and can't always tell the prescriber how they feel or what is causing the behavior or how the medication is helping or not helping. So it's important for those of us who are supporting people with intellectual disabilities to be part of the process of monitoring these meds so that we can answer some of these questions. So the prescriber's role and responsibility is to make sure that the med is being prescribed for one of the reasons that we listed previously, and that they are monitoring it and making sure that the meds are at the right dosage and are at the right, are the right meds, the right med combination, that there's no side effects with other medications that might be prescribed by this prescriber or other prescribers. So they have a lot of responsibility. It's a big, huge responsibility to be the prescriber. But we also, as supporters, have a big responsibility too, and are in a unique position to help the prescribers make the decisions that they make. And because we see the person more often and have experienced some of the behaviors. The same is true of guardians and family supporters. And the BSC in New Mexico is responsible for monitoring psychotropic meds. And we need help with that because we aren't there every day. So we do turn to the direct support professionals and family members to see if there are side effects that are occurring, if the person is overly medicated and maybe be sedated or having different behaviors. We also have the agency nurse who helps monitor the psychotropic meds, healthcare coordinators in New Mexico. We have not only nurses, but healthcare coordinators, service coordinators for the agencies that are involved, and case managers who oversee all of the services through the DD waiver. All of these people can play a key role in monitoring psychotropic med use. And we do have a difference between prescribed medication versus PRN medications. And the BSC in New Mexico is responsible for writing a PRN psychotropic med plan if those medications are prescribed. So we need to work with the prescriber to make sure that it's all copacetic. We also monitor the regularly prescribed psychotropic meds as per the DD waiver standards. So ideally, we want to rule out any other causes of the behavior of concern. We want to make sure that they're not just experiencing some pain or having some depression or grief. We want to make sure that person's environment hasn't changed, and that's what's causing some changes in behavior or symptoms that we might think look like mental health issues. So it's really important that we rule out all of these things before we even go to a prescriber, and maybe describing the behavior to a prescriber sometimes leads to prescription of psychotropic meds because they don't know what else to do. We also want to think about whether the person might be hungry, they might be experiencing fluctuating blood sugar, they could be dehydrated, person could have food intolerances, lactose intolerances, gluten intolerances, other allergies. All of these things are very common with many people with neurodiversities or who are neurodivergent. Are there medication interactions that are causing discomfort, which lead to behavioral issues? There could be simple things. Maybe the person is just trying to tell us something. Maybe they have their shoes aren't fitting right. Their clothes feel uncomfortable. They don't like the way they, fabric feels against their skin. Lots of things that you can probably think of, other things that might cause a person to engage in challenging behaviors, and we can avoid psychotropic meds if we just address those things. So the team helps the BSC conduct a functional behavioral assessment, and the goal is to replace the meds with those positive behavior supports that the BSC develops with the team. There's a lot of cautions to using psychotropic meds, and I'm not totally against psychotropic meds, but in my practice over the last 40 years, I have seen a lot of use of psychotropic meds with people with intellectual disabilities that seems excessive sometimes. So we want to look at these cautions, and I'm going to go over them kind of quickly, but you can come back and think about that, or talk to your BSC about it, because these are really help us to monitor psychotropic meds. So one of the cautions is that there's never a re-examination, or often is not a re-examination of the original decision to prescribe the meds. Maybe the person changes doctors and the new doctor just goes ahead and prescribes the same meds, just without really examining the use of it. I've seen that quite a few times. Oops, let's see if I skipped something here. Okay, caution number 2 is an inadequate assessment. When the med is prescribed without a thorough assessment, it can be, we could avoid that sometimes. We could avoid the med by looking at those things that we already talked about. Haphazard prescribing. Sometimes doctors like a certain med and they'll give it to pretty much anyone, or they'll discontinue and substitute another med without really too much thinking about it. Sometimes number 4 is prescribing psychotropic meds for the convenience of caregivers. You know, somebody has behaviors that are challenging, and you know, maybe we haven't even taken the time to try to figure out what else would work. Seen this a lot too, when we could make some small changes, and instead of over medicating someone or medicating them for behaviors, we could be making changes in their environment. Sometimes it's a staff person, and we hate to admit that, but it could be our approach with the person. And so we don't want to prescribe psychotropic meds for those kind of situations. So we might be also, number 5, ignoring the message that the person is attempting to communicate with behavior. A lot of people with intellectual disabilities have limited communication skills, and so their communication is behavior. This happens with people with communication skills, so it's probably pretty prevalent with adults and children with intellectual disabilities. So we want to make sure we're not ignoring the message. So sometimes number 6 will say we are interpreting an understandable behavioral response as pathological. Okay, so somebody is having a really depressed life, but instead of giving them meds, maybe we could just add some meaning to their life. They might be angry or fearful or sad or lonely. We don't want to medicate for those kinds of feelings. That's not one of the 6 reasons to prescribe psychotropic meds. And this might be the only way they know how to communicate those things. So we also use them to limit autonomy. And we don't always know if the person is expressing his reaction. Do they feel better or worse? We want to make sure that we get their input as much as possible, so we don't limit their autonomy over the medications that they're taking. And caution number 8 is oftentimes the meds are prescribed at a higher dose than is really needed. So even if the medication is helping, it might still be over medicating someone. We want to start with the lowest possible dose and work up, but sometimes the prescriber knows that they're not going to see the person again, so they start a little higher, And then it can be harder to get the person off the med or to lower the dose in those cases. All right, so those are our cautions. Well, we do have another one. Caution number 9 is the caregiver's lacking knowledge. So the person that's bringing the individual to the prescriber should have some knowledge about prescription medication and psychotropic meds. Otherwise, you're more likely to get more meds if the person doesn't have some information, not only about the person, but about the meds that they're taking. And number 10, sometimes we have lack administration of PRN medications. There's a typo in there. We want to make sure that we're using that appropriately too. Sometimes PRN medications are prescribed for people that maybe they have some times when they get highly agitated, and their danger and might be hurting themselves or at risk of hurting themselves or hurting someone else, and then they will be prescribed a PRN medication to address those issues. But we want to make sure that we are really monitoring that, because those are usually pretty habit-forming meds and pretty sedating. So we don't want to just be giving them all the time for every little incident. Number 11 is using medication to mask abuse. Some of these are related to each other, but it's kind of for the caregivers. The other one that said for the caregiver's convenience. Sometimes people have legitimate complaints, and so we're masking that abuse, whether we mean to or not. It can happen. And number 12, I believe this is the last one, using medication as a substitute for appropriate support. So I think that is pretty self-explanatory, rather than using it as like a babysitter to keep the person from having really any behaviors. We want to make sure we have a meaningful program in place for the person. So as a review of the cautions, we want to heed all of those cautions and think about that. We want to rule out all other possible causes of challenges before resorting to medications for behavioral health issues. We want to use any PBS strategies that have been developed, or we want to develop some PBS strategies. By that, we're talking about positive behavior support strategies. That's another training if you want it. And those are usually developed by a behavior support consultant or a behavior therapist. And we also want to communicate with team members. It's so important with people who have limited communication skills. It's so important that we all communicate with each other so that we're providing the best possible quality of care and using psychotropic meds only when absolutely necessary. That includes talking to the prescriber and having a relationship with the prescriber. Now, you want to be careful with prescribers because we're not doctors, unless you are a doctor. I don't even play a doctor on TV because I can't act, and I probably am not even that good at math. So I don't know what that has to do with it, but so consulting with the prescribing physician or prescriber before the visit, it's important for the team to frame the reason for seeking the doctor's consultation. Otherwise, we end up with psychotropic meds when that's not really what we were hoping for. So this will assure that it's not mistaken assumptions that the people are expecting pharmacological solutions to the problem they have identified. So that's why it's important to go over all these things before making that appointment. Some questions to ask the doctor are, what is the medication being given for? It's important to ask about every single med that's prescribed. Even if they get annoyed with you, be a curious George. A specific diagnosis or particular symptom, what is it for? What is the brand name and the generic name? Because sometimes people are already taking a medication and it's the same medication. So we want to be careful with that, or just knowing how we can do some research on our own. What are the difference in effectiveness? If there's a generic versus a brand name, is there a difference in the effectiveness? If they're changing a med, we also want to know if there's difference. Even if it's the same class of medication, we want to know, what the difference might be. These are some questions you can ask, and this comes from the No Easy Answers. You can see up on the top the website to find that publication. It's also in your handout. A lot of this stuff that in the training today comes from that publication, but I just wanted to point that out again. Developmental and psychiatric diagnosis are the target signs and symptoms and behaviors consistent with the diagnosis. All right, so that's a question to ask the doctor. So if they have a diagnosis, do they have the signs and symptoms of that diagnosis? The doctor can tell you that, because that is, what they're looking for too. What is the rationale for the selected medication for this person's symptoms and diagnosis? And you can frame these questions a little bit differently so that they're how you would ask them, but this is the basic meat of the matter. What benefits does the physician anticipate from use of this medication? What consequences if the prescribed psychotropic medication is not used? How will the medication interact with other prescription and non-prescription drugs used by the person? You want to make sure that the doctor is aware of any other prescriptions. Sometimes you go to multiple doctors and they're not always communicating with each other. You want to be sure that they do have that information. The one about if the med is not used, and that could be in general if it's not used, or if the person refuses to take the med one day, or overall doesn't like to take the med, we want to know what will happen. And then the last one is, what side effects should the team members look for from this medication? There can be an awful lot of side effects. More questions. When should the effect of the drug begin? And what changes should be monitored? So how long is it going to take for this medication to kick in? What are we looking for? What changes? Will the initial dose change? In other words, is the medication going to stay at this dose, or does the prescriber anticipate that they'll start at a low dose and increase it over time? What additional resources or treatment to supplement the medication intervention? Should the medication be taken with food? Before eating? After eating? Will the medication interact with certain foods? Some medications cannot be taken with certain foods. You're going to make sure that some of the older medications especially have interactions, but can be very useful in addressing some of these symptoms. So you want to make sure have that information, and that everyone that's working with the person has that information, or living with the person, and that the person themselves know that they shouldn't be eating certain foods with their meds. How often should this prescription be checked by the doctor? Is that going to be more at first, and later, once the med is shown to be effective, then maybe the doctor is going to back off on checking, and you should be monitoring, we should be monitoring, the BSCs, the team should also be monitoring, because you might need to take the person back to the doctor earlier than expected. Are there laboratory tests to schedule? Some of the meds need to have labs because they, you get a high dose of the meds in your system, or other reasons that the doctor can explain. And when is the next appointment? How will we know if the medication is working the way it's supposed to? Again, we're asking the doctor these questions. How long before we have an adequate trial? And we talked about that before meal, after meal, at bedtime. So these are the types of meds that are considered psychotropic meds that we're talking about today. We have antipsychotic meds, which can be typical and atypical, antidepressants, mood stabilizers, anti-anxiety agents, stimulants, hypnotics, ADHD meds, and there are some alternative treatments. And we always want to keep in mind the reasons for the use of these medications that we covered earlier in this video. So these are some examples of antipsychotic, neuroleptic medications, and some of the reasons that they might be given. Or Tourette's on that one. This is one that is used with Tourette's sometimes. These are some of the generic names. Some more of the typical antipsychotic medications. Some of the common ones that you see are Haldol is really popular. Then there's atypical antipsychotic medications, which are newer antipsychotic, and they have somewhat less negative symptoms, although they have found that that's not always the case either. But these are some of the atypical antipsychotics that you might see prescribed to your clients or the person that you're supporting. And the one that I've seen the most is Risperdal. I've also seen Zyprexa and Abilify. Actually seen all of these at one time or another. I think the most common would be Risperdal and Zyprexa. And those are really serious medications with some, even though they're less side effects than the older ones, they still have some pretty serious side effects that we want to be aware of. Some of the antidepressants here, and there's different types of antidepressants that work differently. These are just a few examples. Most of us have heard of Prozac, but there's other ones that are pretty common too. Some more antidepressants. Zoloft can be used during pregnancy. In the event that you have a client that is pregnant and needs an antidepressant, that might be a choice. The doctor might recommend or prescribe. Then there's mood stabilizers, which are also used to treat seizure disorders. Tegretol and Depakote, I've seen them both quite often. More mood stabilizers that are a little more, I would say, dangerous because they have some serious side effects, what they call black box warnings. Then there's anti-anxiety and hypnotic medications. And more some anti-anxiety. See, that's why I wouldn't be a very good actress. I can't even, not even very clear, but these are some more anti-anxiety medications. A lot of anti-anxiety medications are habit forming and you become addicted to them, so they should be used sparingly. And maybe they're used as PRNs more often than regularly prescribed. And some more. And then So that's the review of the meds. The other thing that you can sometimes see people prescribed are things like St. John's wort or valerian, kava kava. Those are herbal antipsychotics, but they also should be prescribed by a physician or at least consult with a physician before taking them, because they can have side effects and interactions as well. So then we're going to talk a little bit about tardive dyskinesia. It is probably the most serious side effect that the antipsychotics and some of the other medications that we just reviewed can cause. And they can cause, it's characterized by slow, repetitive, involuntary movement. And on the DDSD website in New Mexico, they do have a whole handout on tardive dyskinesia that can be helpful if you're seeing any of those symptoms or if you have people who are prescribed any of these meds. These are some more of the characteristics of tardive dyskinesia. You see any of these things, be sure and talk to your prescriber or the person's prescriber. And it can be long-term and doesn't necessarily occur immediately after the person starts taking the meds, and they can be irreversible. If it's generally considered to be irreversible, but they can wax and wane in severity. And these are some of the meds that do cause tardive dyskinesia. These are just some of them. There are others. There's a lot. Most of them are the antipsychotics. They did think in the beginning that the atypicals would not cause so much of these symptoms, but they have been proven wrong. These are some other meds that can cause tardive dyskinesia. And again, if you want more information, I would go to the DDSD website, or you can find information online, of course. So basically, when we're monitoring psychotropic meds, we want to know what the medication, what type of medication is it? Like we just went through the types. I don't expect you to remember all of them, but you can ask the doctor what type, and now you have a general idea where it might fall. Generic versus brand name, what it's used for. Is there a particular diagnosis it's used for? What are the side effects, interactions, and other information that might be helpful or of interest? All right. Then on your handout, you will find the reference list where I found most of the information for this video. All right. There are 2 handouts that go with the video. So if you are with the training, so if you're doing the full training, you'll want to make sure you have those handouts. Thank you so much for joining me today. I know that it's kind of dry, but I appreciate you being here. Thanks again, and I'll see you next time. And please comment in the comments section, especially if you want more information or to give me some feedback on the video. And the best resource that I've found on this topic is, again, the book or pamphlet, No Easy Answer. And that can be found at this website. All right, and that's all, folks. Thank you so much.